morning, everyone. It's such a pleasure to have Sandy with us this morning. Thank you so much for being with us. Sandy is an amazing communicator. For those that don't know her, she's an international lecturer. She has helped many practices throughout the years communicate better with their team members, with their practice. The first time I heard her at the AACD, I knew I needed to change something about my practice. She always has new ideas, new ways of doing things, and she's constantly evolving. And that's what I love about Sandy. Every time I meet her, she's constantly changing the status quo. And I'm sure her lecture today is going to be thought-provoking and entertaining, as always. I want to add also that Sandy is one of the most generous people I've ever met throughout her charities and also helping us at Oryx by giving us a lot of her material to use, helping us with our risk assessment when we needed to communicate better with the patient. Sandy, thank you for all your help. We all appreciate you so much. And I'm gonna leave it up to you. You go.
So in 1973, my husband graduated from dental school. And in the course of getting involved with the National Health Service Corps, which was a part of the Public Health Service back then, and bringing dental care to rural communities, he received a copy of this book. You can see how technical my presentation is going to be. The name of this book is Successful Preventive Dental Practices, and it was written by a dentist by the name of Bob Barkley. Bob Barkley practiced in Macomb, Illinois, which was a tiny little town in southern Illinois. His whole approach was shaken when he had a 21-year-old young woman return to his practice with full extraction of her teeth after he had recommended root canals and crowns and bridges and things like that. And he asked himself a very, very important question. What am I missing here? How could I have condemned this young woman to a lifetime of dental death with dentures? Now, this would have been in the 70s. Sadly, Dr. Barkley was killed in a private plane crash in 1976. But his legacy goes on in this book, which was reprinted but is out of print now. And one of the things that is notable about Bob Barkley was that he really was the first person to start talking about prevention and how we mitigate the implications of dental disease in the mouths of our patients. Coincidentally, a few years later, Doug and I happened to be in an antiquarian bookstore, and we found this blue folder with onion skin. Now, a lot of you young people have no idea what that is, but it was basically a second page. When you typed, you put the paper there, you put the carbon paper behind it, and a piece of onion skin. And there were all of these letters, the onion skin copies that Dr. Barkley had written to his patients. How we came upon it, I have no idea. But what a treasure. Because what we saw in these letters that Barkley wrote to his patients was a human being connecting and communicating with another human being, person to person. His letters were all in lay language. They were full of compassion. They included dental information for the patient, and they were primarily designed to help return, as I interpreted it, return the patient's problem to them. Because in the lack of ownership, patients don't act. If you have a condition or a situation or whatever it is, and you don't care about it, you're unlikely to take action. You know this from all the things that go on in your own life. You have a relative who's a diabetic, and yet they don't take their medication, they don't exercise, they do don't do whatever it is that they're meant to be doing. There are other people who are diabetics who are very religious in their approach to things because the disease is owned. They own it. So if you own the problem of the disease, you can participate in your own care. And that's a lot of what Dr. Barkley was talking about. Years later, in my husband's own practice, he tried very hard to replicate the concept of these letters, and he had to do them one by one. Now, why am I telling you this? Because throughout my career as a consultant, I have continued to encourage, invite, really bring my clients into an understanding that they've got to connect on a human level with these people who voluntarily come to them, right? Nobody comes unless they're volunteers, and continue to volunteer to come back. They've got to connect with those people on an emotional level as well as an intellectual level. And because it's so time and resource intensive to write this kind of letter to every single patient, as we would if we could, I have begged every single dental software company I have come into contact with, and there are many of them, please, can you find a way to put into your software a way of translating clinical findings into something that's meaningful, understandable, and helpful to the patient so that they can accept ownership of their disease or their problem or their issue and participate in the solution. All of that fell on deaf ears until I learned about what Rania was doing. And Oryx software is the manifestation of those efforts. I have supported and encouraged anything that I felt was going to help bring about some kind of change in the way we connect with our patients. Rania, I'm going to ask you, am I on the screen? Because I'm seeing your name right now. I just want to make sure that people are going to see what I'm going to hold up.
Yes, you are. We can see.
Okay, thank you. All right, so here is what I want us to talk about today. Normally my approach to helping people in programs at COIS, at AACD, at whatever it is I'm doing, is very interactive conversations. That's not something we can do in person now. So I'm going to ask you to participate by following a few things that I'm going to ask you to do. So number one, I'm hoping you all have a piece of paper in front of you and some kind of writing implement, because I'm going to give you a couple of things that I would like for you to write down. And then I'm going to ask you to stop for just a moment and reflect on some of the questions and the thoughts that I'm going to bring to your attention. All right. So here's where I want to begin. I said to you just a moment ago that anybody who comes into your practice is a volunteer. They volunteer. They're not required to come. There's nobody with a gun to their head. So they come for some reason. That reason is sometimes more knowable to them than not. Sometimes people come, they're not really sure, but there's something that's not right for them. So my feeling is that job number one for all of you is to find out why that patient bothered, didn't do something else that day, interrupted their lovely life to get in their car or get on a bus and go all the way through the process of getting to you. Why did they do that? There's got to be some reason that's more important than whatever else they could have done. So this is my little high technical graph I want you to do. I'm going to hold this up and make sure I can see it. My little screen is really small, so I'm not sure if you're getting all of this. The title of this is How Patients Make Choices. And I want you on your paper to draw those 4 squares that I have on there. Sort of like 2 eyes, a nose, and a mouth. It's a really simple thing to do. Now, we can't help people make choices if we don't understand how they go about making choices. So step number one is to find out why they came in the first place. These are the little parts that I want you to fill in on each of these 4 squares, and I hope you can see it. The first I is problem. The second I is condition. The nose is solution. And the mouth is prices. We're going to go about filling in those squares as we move through this. Problem, condition, solution, and prices. Here's the simple part of this. People don't come to the dentist for no reason at all. People come to the dentist because they have a problem. Now, I want to make a very strict distinction between the notion of a problem and the notion of a condition. You dentists worry about conditions. We non-dentists, behavioral people, and normal human beings worry about problems. There are only 4 types of problems a patient can have. If they don't have one of these 4, they don't come to the dentist. And here are the 4 problems. I'll just do this one. How things look, how things feel, how things work, and POM, which is peace of mind. How things look, how things feel, how things work, and peace of mind issues. So let's talk about what that means for a minute. If I don't like the way my teeth look, I might be compelled to come to the dentist. If I have a pain and the pain is debilitating and I don't like the way it feels, I might come to the dentist. If I can't chew because I'm missing teeth or I'm out of occlusion or whatever it is, I might choose to come to the dentist. If, on the other hand, I'm worried, I don't have peace of mind, my mother lost her teeth, my father lost his teeth, my grandmother lost her teeth, am I going to lose my teeth? I'm going overseas for a trip. Well, not right now we're going overseas, but you get the idea. I'm going overseas for a trip and I'm going to be in Tibet for 2 months. Can you make sure I'm okay before I go? That's peace of mind issues. Now, in the absence of any one or a combination of those 4, people don't voluntarily come to the dentist. Why do people come with regularity for a hygiene appointment, as prescribed or encouraged by their dentist? It's because they want to make sure they're still okay. So here's the take-home message of this little bit. Your first job, beyond knowing anything else about them other than their name and their address and phone number maybe, is to find out why that person has bothered to come and see you. What's their agenda? What do they perceive their problem to be? So when a patient calls, that person who's answering that phone cannot simply be a record keeper, cannot be a data collector. That person's agenda has got to be to begin to understand why that patient bothered to call you in the first place. So the question is, Mrs. Jones, I'd love to get a better sense of what you'd like Dr. Smith to be looking at for you when you come for your first appointment. Now, you'll get that on Oryx and the medical and dental history information that patients get. You will get to that, but let's begin on the human level before we get to the record keeping level. You've got an opportunity here. And one of the things you're going to hear me talk about over and over and over again is that every single member of your team who has patient contact has got to become informed and engaged with that patient at every single point of contact. Has to be. You've got lots of time right now. If your practice is down because of the coronavirus or whatever it is that's still going on for you, you've got time for your team members to start learning about your patients. What a great opportunity this is in a bad time. So that person who is answering that phone has to begin the process of peeling back that onion, because there are layers in there, and we want to get to where those layers take us. It matters if the patient says that they have a concern because they're going away for 6 months. It matters if the person says they have a pain that they'd like to have taken care of. Those distinctions matter. It doesn't necessarily change your clinical standard. It doesn't change your procedure. It doesn't change your process necessarily, but it matters about your mindset in receiving and taking care of that person. Those are the 4 problems. In the absence of those, people don't come to you. In the presence of any one of those, you need to understand what they are. And you've got to understand it by starting to ask them. Let me make the connection. Here's the second one, condition. You know what a condition is? It's your clinical findings. When you do the examination, you are looking for clinical findings. And one of the most powerful things you can do when you engaged in your examination is to connect clinical findings to the reason the patient came in the first place. Aha, no wonder your tooth hurts. There's an abscess. I can show you that on the radiograph. Aha, no wonder you can't chew on that side. That tooth is broken in half. They're not coming together in a way that allows you to chew properly. Aha, these are the things that you can start to make connections for. This whole process is about helping people, as Bob Barkley talked about, own their problems through an understanding of the conditions that are causal factors. So a clinical finding is not a problem. I can have a broken tooth and it doesn't bother me, so it's not a problem for me. You might not like it, but it's not a problem for me. A clinical finding is a causal factor of a problem the patient is exhibiting. Think about how powerful that is for you. The patient says, this is my problem, and they explain it really, really clearly. And you're able, through your examination, to discover the causal factors. Now, will you always find that? Of course not. But where you do, begin to make those linkages and connections right away. They're very, very important. Now, here we go from here. Now that you have, here we go. Now that you have identified the clinical findings, you know what you're going to come up with? Solutions. Those are your treatment plans. So if you say to the patient, look, I have a solution that will attack the condition that is the causal factor of your problem. Now your treatment plan makes sense. In the absence of that, you know what happens? You say, look, I've got a solution to a condition I see that the patient may not own, they may not be able to relate to, and they may not care about. So when we ask people to price test it, price testing is, don't you love my technical stuff here? Look, there are 5 prices people have to pay for your dental care. Time, money, there's a euro there in case you don't like the dollar, effort, courage, and risk of discomfort. Time. I have to decide if I want to spend the time to have a 1.5 years of ortho to get the appearance issues I'd like to achieve. Can you see my Invisalign little dots? I have to decide if I want to spend that time, or if I want to spend the time coming to a series of appointments to agree to the treatment plan that you said is going to fix the condition that is causing my problem. I have to decide if I want or can spend the money. Money is not a little thing, and it will be not a little thing in spades when people get back to work and the pandemic begins to resolve in some kind of a meaningful way. Money is going to be a big determinator for lots of people. So be prepared for that. They will price test. Do I want this problem I have fixed by your solution enough to pay the dollars, the euros that you're asking me to pay? Courage. I'm afraid. Can I get enough courage up to actually take myself through this process? You know, some people are still fearful of going through they're afraid of the needle, they're afraid of the sounds, they're afraid of the smell, whatever it is. Courage is not a little thing for some people. Energy. Do I want to work this hard? Time, money, energy, effort, same as energy. Courage, comfort, risk of discomfort. Is this going to hurt? Do I want to go through this? The last time I had a tooth out, I had a dry socket, blah, 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 blah. And they will go through these. That's price testing. Now, here's the part that's really important. You don't want people price testing at home alone without some help from you. Now, if you don't know anything about them, if you don't know what their agenda is, if you don't know what they perceive their problem is, they're going to go home and their spouse or their partner is going to say, well, how much? They're going to say X number of dollars. And the partner who is not involved in all of this knowing and knowledge and engagement is going to say, well, let me find somebody cheaper. We want people to price test in this way. Do I want my problem fixed enough to pay these prices? Not do I want to pay the prices for the solution you came up with. Do I want my problem that brought me in here in the first place eradicated enough or modified or changed enough to pay these prices you're asking me to pay? Now, I hope you listen to this over and over again until you get it. This is so fundamental, from my opinion, as a behavioral person. It's not negotiable. It's just simply not negotiable. If you're going to have a thriving practice, you absolutely have to have an understanding of all of this. Now, what does that have to do with what we're talking about today in terms of Oryx and your team and having this information readily available? If we go back to Bob Barkley, what he says in his book, look, it's antiquated. It was 1972, right? Still sound. Human beings don't change that much. Human beings want their lives to be better, and they think you can make it better for them. So we need to receive them in that way. And while Bob Barkley could sit there and write an individual letter to every single one of his patients, it's not a reasonable expectation for us, but we have a tool now that helps us to do that. This report that you can get is so critically important to helping patients understand their disease, accept ownership, and participate in decisions about how to resolve those. Now, the world has changed. You know that when you go into any kind of business, let's say you're going to call your insurance company and you say, something broke, my window blew out, we had a tornado, whatever it is. And the person answering the phone says, oh, you have to talk to Joe. And they put you on death-defying hold, and then you've got to go talk to Joe again. And then Joe isn't really the right person, so they send you to Mary. by the time you get through with that, you're exasperated and you have not been treated well. I think a lot of people experience that in dental practices as well. If I call your dental practice, let's say I'm a patient who's been coming to you for a while, and the person who answers the phone doesn't know me, has no understanding of my agenda, what I've been through, what I'm going through, what we're planning together, what my issues are, what my price testing prospects have been. If that person is unaware, then you've missed an enormous opportunity, because let me tell you, there are very few dental practices out there that make it the business of their team members to know everybody at the level that I believe they need to know them. We have to find a way to bridge this technical advantage we have with an Oryx dental computer software system, with the clinical information you put into it, and the prospects of how we engage our patients. And the bottom line is that's the team members. The team members, oh, I just praise you so much. You are so important. I have known over my, 30 years practicing and consulting in dentistry, I have known many, an exquisitely skilled dentist with a bunch of bobbleheads for team members who will never be successful until he or she gets people on board who are smart, who are engaged, who love what they do, who care about people, and who are able to bring all of this information to whatever it is they're doing in the practice. You know, the days of the dental hygienist, because I've seen many of them over the years, the days of the dental hygienist being concerned about soft tissue and I don't really do teeth are long over. The days of the dental assistant being a piece of furniture, handing instruments to the dentist and not engaging either the dentist or the patient in dialogue and discussion, long over. The days of the person at reception being hired because they're bubbly, but who really can't immerse in an understanding of patients and how we need to understand and talk to them and care for them, long over. It's a new day entirely. One of the things we know is that if it's not written down, it didn't happen. You all know that from risk management issues. That's what your insurance carrier tells you. That's what all of us tell you every time we get a chance to do that. If it's not written down, it didn't happen. Every conversation with every patient absolutely has to be documented. Because if I'm at a non-clinical area, let's say I'm at reception or I'm at patient coordination or whatever you're going to call these non-clinical roles, and a patient rings on the phone and I'm not able to get that information quickly, go into the computer, quickly read the last series of notes, not just the clinical treatment plan, that's important, but be able to look at things and help me figure out how to proceed with this patient. Here's a perfect example. I know how to read a proper dental chart. I know how to read missing teeth. I know how to read which teeth have been repaired, restored with crowns or bridges or gold inlays or whatever it is. I know how to read the red spots that tell me on the distal of this particular tooth there's decay at the gum line. I know how to read that. So when a patient rings in the practice, I'm able to bring up notes. I'm able to bring up the chart. I'm able to look at the treatment plan quickly. So when the patient says, I'm having some pain right down here, I need to see the dentist. I said, you know what, I'm going to help you. Let's see. Just give me 2 seconds. I look at that quickly and I say, you know, Mrs. Jones, that's that area of decay down there that Dr. Smith talked about the last time. Now, here's what his note says about that blah, blah, blah. He's recommending this. I know that you told us it was not financially a good idea right now. I'm wondering if that's changed for you, because it sounds like your tooth is wanting a little more help. That conversation at the telephone, look at what that saves for you. It's economical, but it's very, very effective. Yes, we want efficiency, but we want effectiveness as well. I'm able to say to the person, how are you feeling about that now? What would you like to proceed with that? We already know what the doctor's recommended. What are you thinking? And I can schedule that patient for that procedure right then and there. Listen, if I don't know any of that, well, just a second, let me check. I have to ask the assistant, the hygienist, I have to get the doctor in between. I'll call you back. I have to, well, bring them in for a look. Look at all of what we've done. It's incredibly annoying to patients, I can tell you that. It's inefficient and it's ineffective. So John talks about this all the time, bringing efficiency and effectiveness into partnership with one another. So how can your human contact mesh with your technology? If you have a very powerful piece of software like Oryx, and you're not putting stuff in, that has to change. If you have a powerful piece of software like Oryx, and you're not looking at it, that has to change. If your team members don't know how to read and interpret and understand basic stuff, that has to change. So I want to stop, see what some of your comments or questions are, if you have them at this point, and then we can always go forward with that. Ronnie, are there things that people have raised?
Yes, Sandy. So I'll start with the first question, and it's, do you promote the idea of having the team members cross-trained?
This is such a good question. Part of my graduate work was in industrial psychology, and industrial psychology has to do with time and motion systems and this kind of stuff. I'm not a fan of cross-training, and here's why. I don't want to put team members in a blender and puree and have everybody come out essentially the same. I also know that we each have our strengths. I want to promote the strengths of each individual person and make sure that every person gets the opportunity to maximize what his or her skill set is. Having said that, I do believe every member of the team has to understand basic things about the business of dentistry, about how we go about doing what we're doing and how we approach patient care. So there's a difference in my mind between cross-training, and I can tell you what that typically is. If Jane is out at the front desk, we take an assistant and pop her up there, and she doesn't understand the day-to-day functions of those tasks. I don't believe in cross-training tasks. I do believe in a common understanding of a number of things. One of them is how the practice functions, enough about dentistry that people can answer and address basic questions. But here's another thing. I think every member of the team has to understand very clearly who this dentist is, what her belief systems are, what her ethics are, what she stands for, what her style is. Because you will get a phone call from a patient who says, I just think the dentist is trying to rip me off. Now, if I don't know my dentist, I'm going to say, let me get somebody for you. If I do know my dentist at that level, I'm able to say, Mrs. Jones, I'm taken back by that perspective. I really need to understand what makes you think that, because that's so different what I believe Dr. Jones is all about. So please help me with that. Now, here's what that takes. You cannot be a shrinking violet. You've got to be a person who's got confidence. You've got to know that you stand on solid ground, that your dentists are going to support you when you gently moved into conflict like that. If your team members are shrinking violets and they have no backbone and they don't know where they stand and they're afraid if they have that conversation, you're going to pull the rug out from under them. Shame on you. You're not a good leader. Shame on you. On the other hand, if part of what you make your team aware of is who you are, what you believe, what's important, listen, if your agenda in dentistry is to screw patients and make a lot of money, I need to know that. Then I can decide if I can work for you or not. I don't think that's what you're about. I need to understand how you would represent yourself to others and what you stand for, what your beliefs are. And In every case, team members have to know and understand you, your ethics, your belief systems, your standard of care so well that they can represent you in your absence. It may not be that we can ever assuage this patient's comments. Oh, what's the choice? Oh, I'm sorry to hear that. Okay, we'll send your records on. That makes no sense. We can't afford that. So that's my answer to the issue of cross-training. Not a fan.
So Bobby has a follow-up question on that, and she's saying, so you're saying that if the front desk team are busy, then an assistant can print a simple insurance form or take a payment?
Well, that's a task. And I'm going to guess that Bobby has a little agenda there, because that's a little passive-aggressive question, but I don't, maybe not. Okay, I'll back off of that. But I mean, of course, part of what we have to do is we have to help each other out. We have to be aware. This is, listen, part of what being a team means is not that we cross-train so that we can jump in all the time. We need to stay in our wheelhouses, right? But of course, if I'm an assistant and I'm completing with a patient, and this patient knows, because we have it in the computer, this is what we're going to do today. This is going to be the fee today. This is what the patient is expecting to pay today. That's what I mean about we've got all this stuff. We don't use it. I take the patient up, and let's say there's one person at reception and she's engaged on the phone with a new patient. Of course I'm going to complete that appointment. Of course I'm going to. It's a kind thing to do. It's the right thing to do. But this is not the front versus the back. I want to make sure we don't get into that part.
Okay. So Jeremy is asking you, can you give us a few ideas on how to open a conversation about what brings you in to see us today when they answer with my cleaning?
Well, if that's what they answer, I would say, well, I'd like to have a little bit more information about your last dental practice and what they were working on, and how we could contact them to find out what they were working on with you. What's your understanding of the frequency of cleanings that they've recommended and why they recommended that frequency? So you simply want to see what, here's what happens. And Jeremy knows this really, really well, because he's like one of the smartest guys on the face of the earth, in my opinion. What I think happens is that we train people to get into this habit. It's a habit, but they don't always own it. So, I come in, I don't come in. What the hell, I can cancel it, whatever. So I think we need to sort of dig down a little bit more. Now, trust me, I'm not suggesting we want to annoy people. If people are not forthcoming, we stop. Of course we do. Well, we'll learn a little bit more about you when we see you at your first appointment, and then you go on to whatever you're going. So I liken it to this. Those of you who drink martinis with olives know that most olives come in this really tall jar, right? And they've got big olives in there in liquid. And if you unscrew the top of the olive jar and you turn it upside down, the liquid comes out, but the olives are still inside. I think about that initial phone call is taking the first olive out of the jar. Because when they come in the next time and you turn the olive jar upside down, they all start flowing out. So I want to start the process by taking the first olive out of the jar to get the patient to begin to communicate openly with us about their agenda.
All right. So what is it that Oryx uniquely do to implement this communication when the phone rings?
Well, I can tell you, I'm just going to tell you now, I'm not an Oryx expert. I have a lot of clients who are, and of course, Rania is. The main thing that I have worked on with Oryx is getting the information that follows the examination in the 4 food groups that Kois works on into a way that helps people to understand things. So, Rania, if you want to have a go at that, that's helpful.
Yeah, so when the patients complete the medical and dental history questionnaire, we already know the risk of the patient in 4 different categories. So we know if they're high risk, moderate risk, or low risk for gum disease, for teeth health, for bite and jaw joint, and their smile. So when the phone rings and they already filled their forms out, or if the examination was done, you already kind of know what patient you're dealing with. If it's a patient that you know that are high risk for perio and they're calling with a lot of pain, then you know that might be a perio abscess. If it's a patient with a lot of issue with TMJ, then you might know that it's their jaw joint. So in that way, Oryx makes it really easy to look at the 4 food groups, like John calls it, and know right away what kind of patient you're going to be seeing.
In general, you're a detective. I used to be a police officer in Philadelphia, and one of the things we did was we snooped around and we looked at things and we asked questions and we took rocks up and we looked at what was under, and we followed the evidence, we followed the trails. That's exactly what you're doing with a new patient. You're following the evidence, you're following the trails. And the thing about Oryx is you've got a wonderful place to record all of that. Write it down so the next person, I think about this whole process is like a relay race. We're not going to have the Olympics this year. I'm so disappointed, but I understand. So you think about a 4x100 meter relay. The first person starts and they have this baton. That's the first contact with the patient. They get up to the second person on the race. They hand the baton to that person, and they go around until the third person and then the fourth person. And you've got to get across the finish line with the baton. That's the way the team has to function together. Think about that. How do we hand off to the next person so we never drop the baton?
So EW is asking, patients may know intellectually what their problems are, but often still make poor choices for themselves. How do you ensure that they engage on the emotional level that will actually motivate them to take action? What is the best training for the team to help them with the treatment acceptance?
I want to make sure we're talking about problems as I've outlined it. So EW, I get that. Patients, I'm trying to think of something, you know, most of us are right now in sort of self-quarantine. We're sort of staying in. And I saw something, a very funny thing on Facebook lately where our gas bill was $0, our lawn and our entertainment and that kind of stuff was all $0, and our food bill was $3,000, right? So what are we doing right now at home? We're probably eating more than we should. Do we know intellectually we shouldn't eat that cheesecake, but boy, it sure feels good at the time. So that's the process. It's the same. Listen, the process you go through in making ill-advised, maybe not the best choices for yourself. It's the same process patients go through. This is what I want patients to hear. You are always here to help them. You would like to be helping them better than they're letting you help them right now. Mrs. Jones, I understand price testing, remember? I understand finances are a problem for you, and I would love to help you avoid further problems that you've got. I hope you'll let me help you better than I did the last time. I watched John's webinar with you last time, and he was talking about, you know, the patient where, look, I know I can help you better with this full coverage crown that stabilizes that tooth. And yet we know people will opt for what we would call in dentistry patchwork, a filling that we know will not serve that patient over the long term. And of course, if that's clinically, if it fits within your clinical standard of care, of course, you would provide that service for your patient. But it has to come with an understanding that it's not my recommendation. Here are the risks that you are taking, not me, right? John talks about this a lot. These are the risks you've assumed, that you are now risking that this will break at a time when it's least convenient for you. You will have already paid me for this, and you will get to pay me, or I hope not somebody else, but somebody else, to fix this more definitively, and your choices will be fewer. I talk about it in terms of talking with the patients about delaying treatment and the passage of time. We know that dental problems don't spontaneously go away, that with the passage of time, things get more difficult to repair clinically. They get more uncomfortable for the patient, more expensive, less predictable, and the outcome is probably less than ideal. That's what happens with the passage of time. So if you're prepared, Mrs. Jones, to take those risks, I will do these things that fall within my standard. I won't do this. It doesn't fall within my standard of care. I will, of course, do that because I want to help you. And I'm sorry because I would have liked to have helped you better. And listen, the choice is always going to be the patient's. You cannot ever get people to do what they think is not in their best interest. I tell this true story that in my husband's practice some years ago, he identified a treatment plan for a patient, and the guy was in big trouble. And the treatment plan came out to $10,000. Well, this patient went away, never came back until 3 years later. He walked in the front door and he had a stack of what looked like playing cards, but they were the size of dollar bills, and they were all wrapped up with rubber bands. And he came up to me and he said, "Hi, I'm back. Will this do?" And he put $10,000 in $100 bills on the counter. I said, "Yep." Listen, people make choices based on their timeline and their agenda, not yours. And the thing that I find really amazing is that people will change their decision-making based on what happens in their life, not necessarily on yours. One more true story about this. I'm in a practice in Toronto many years ago, and there was this woman who looked like Mrs. Nikita Khrushchev. So if you know, she was like a little babushka, and she was gray and, round and bland. And she was in the hygienist chair, and she had these teeth that were so crowded, there's no way she could clean them properly. And the hygienist was saying, Mrs. Khrushchev, it wasn't really her, of course, Mrs. Khrushchev, orthodontics can help, align those teeth so you could clean them better. She said, "Oh, no, I could never do that. I could never do that." Well, 6 months later, I'm back in this practice, and there is this woman with the same name who doesn't look like her, who's in the schedule that day for an orthodontic adjustment. And I went up and reintroduced myself. And I said, I saw you 6 months ago, and this was not something you were thinking. Help me. What changed? She said, "He died." I said, Who died? She said, "My husband." "Really?" She said, "Yeah, I loved him a lot, but he was a tight old bastard. And once he didn't want to spend a nickel for anything. And once he died, I realized I was sort of a wealthy woman. And I wanted these teeth straightened. And so the first thing I did was made an appointment to come in here and get my teeth straightened." Now, they could have talked about ortho and cleaning and all the problems in the perio, this and that, till the cows came home. Her life had to change first. We can't forget that.
So Dina Lu is asking a question a little bit related to this. Can you expand on how to price test with your patient instead of doing that with the spouse? What are strategies for managing patients who want to stay within their network?
Well, look, this insurance thing is something that just gets my blood boiling. So I can just tell you that from the very, very, very beginning. I think insurance and insurance companies, I quite frankly hope they go away forever. They have not been an advantage for patients, and they have been a real interference to our ability to provide care for our patients. But at any point along the path of dialogue or discussion with a patient, so Mrs. Jones, I understand this is you've come to see us, and you were previously seeing Dr. Smith down the street. I'd be very curious, without you revealing anything private about that practice, of course, what is it that prompted you to seek care elsewhere? Well, all he wanted was my money, or he was never on time, or whatever it was. They will tell you, because they're mad about whatever the last guy was. He had these big, expensive, one person came in to Doug's practice once and said, I got this treatment plan for $40,000. That's more than my trailer cost, right? So when you hear something that you think in any way is a trigger for one of these issues of price testing that patients will go through, that's the time for you to explore it. So when you say all he wanted was your money, I think it's really important for us to understand that, because quite honestly, Mrs. Smith, we don't want to make the same mistake. And it would help me if I understood either if you have a dental budget or you feel there's some limitations or other kinds of things that we should know and understand about you in order not to put you back in the place where you were with Dr. Smith. This is where we can't be wusses. We can't be afraid to ask people about issues that are going to have an impact on their decision making. You know, I went to this guy and he gave this huge treatment plan, and I didn't understand anything about it. I don't know why he wanted to do all these things. There was nothing wrong. Boy, is that a piece of information you better pay attention to. So Mrs. Jones, let me tell, this is why you got to know your doctor. Got to know your doctor's belief and standards and quality of care, all that kind of stuff, ethics. Mrs. Jones, one of the things I know about Dr. Smith is that he would never make a recommendation that was more in his best interest than in yours. And if you ever feel that way, please tell us, because that means we've made a mistake and we want to correct that. And let me tell you about what our goal is today. When Dr. Smith does the examination, we want to make sure you understand what he's seeing and what that means for you, so that you can make a decision about what's in your best interest. This is not a clinical taking people to dental school process. It's understanding them and being able to help them convey to us stuff that's really important. Now, here's a little thing that we all know is true. Sometimes people, this is so fascinating. People are so bloody fascinating, aren't they? Sometimes people say, I can't afford it, when they're really afraid. And some people say, I don't have the time, when they can't afford it. So sometimes that's a signal. People feel unsafe. When people call you at the last minute and they cancel an appointment for a quadrant of dentistry, that's not a them issue, that's a you issue. That means that they didn't feel safe enough with your team to tell you they didn't want to do it in the first place. And they're embarrassed to do that. So they tell you they had to go to Omaha for a meeting. So we need to understand the culture that we're creating that makes people feel safe enough to tell us the truth. And listen, as long as people have insurance, they're going to struggle with this network and co-pays and all that kind of crap that is an impediment to care. If you are accepting dental insurance, or if you're part of those plans, you have to acknowledge that you've made a business decision that is going to have an impact on the way you provide care for your patients. At best, you have to be able to say, listen, if there weren't restrictions from your insurance company, this is what I would be offering you. But because of the insurance restrictions, not mine, this is what your insurance will help you with. And if that's not what you want, then we need to ignore your insurance and do what you believe is in your best interest. And I would concur on that. These are just conversations. We can't rely on the doctor to have all those conversations. Team members have to be empowered. They have to be informed. They have to have courage. They have to know you've got their back, and they have to have the behavioral skills to engage in those conversations with patients. And the only way that's going to happen is when they do it.
So Craig is asking, how would you handle requests for discounts?
A request for discount. Oh my goodness, Mrs. Jones, we've discounted everything we possibly can. End of story. I can't imagine. Listen, I know people do that. So no, oh my goodness, no, Mrs. Jones, we wouldn't want to discount that, because then we'd have to do something less than what we would do anyway. That would be immoral. That would probably be illegal. I'm not willing to put myself at risk. I'm certainly not willing to put you at risk, particularly when people ask for you to waive the copay on their insurance. Oh my gosh, Mrs. Jones, no, I would never put you at risk, because if your insurance company found out, they would take your insurance away from you. Certainly it would threaten my license or my doctor's license. Oh my goodness, no, that would be really improper. I need to know your standard. I need to know what you as the doctor think is ethical, so I can respond appropriately. And you know what happens when you say that to people? Well, it never hurts to ask. And they move on. I mean, they don't move on from you. It never hurts to ask. My dad, my father, he used to drive through the Wendy's pickup, order a chicken sandwich, and ask for a senior discount. Now, what is going on there? But he said it would never hurt. He always got it, by the way. It was like 12 cents. It was just a thing. And the older people get, the more they ask for that stuff. I think it's a hoot.
So, Sandy, someone is asking, some consultants recommend to give the treatment plan in pieces, not the whole treatment, and not to go above a certain dollar amount. Is that what you recommend to do?
Absolutely not. It is unethical. It's deceptive. It is to protect you and not protect your patient. It puts your patient at risk. Listen, this is what you are. You are their clinical advisor. You're the clinical advisor. They can't examine, diagnose, and treatment plan themselves. They're paying you to do that. And if you say to the patient, Mrs. Jones, there are a number of things going on in your mouth that we discovered today, and I identified as we were doing the examination. So it's my job as your clinical advisor to discuss all of those things with you, so that you're in a better position to make decisions about what you think are in your best interest. Absolutely. Do not. That would think of, that just, no, I'm done with that. Sorry.
I'm trying to get all the money questions together.
Okay.
From GW, my wife got a crown done last month at her dentist, and it cost less than what you are quoting. Why are you charging more?
I have no idea about anything about that other dentist. Let me tell you how we set our fees. Our fees are based on what we bring to the issue here. You're not paying for the coffee, by the way. Our fees are based on our experience, on the lab costs, about what we have to do to take care of having the right thing in this practice. And listen, if somebody else can do it for less, and if it's just as good, more power to them. It's just not the way that I can operate. And what you need to know is that I don't charge just because I think I can get more. I charge my fees because it's the right thing for me to do to operate the practice at the standards that I hold. Don't let your patients bully you. Don't be afraid.
So it's a funny one. Does coffee get patients in?
Yeah. Listen, this is a little private story. My husband opened a practice. He's since sold it and retired. And one of the things, we knew our patient base. They were older people. And a lot of them, we live in Florida, a lot of them from New York. So we got the New York Times, and we had coffee in our practice every day. And once people realized that, some of these old guys would come in and sit in our reception room and have a cup of coffee and read the paper. You know what? That was really good for business. They promoted us as a result of that. Of course, it doesn't get them in. It's a nicety. And, you know, if we had the newspaper and the coffee, and we had a bunch of bozos who just talked about their weekend tubing on the river instead of engaging with patients, of course it wouldn't have worked. So it is a nicety. It is a little thing that you add on, but it's not what makes your practice.
So Suki is asking, what do you say when a new patient tells you that he or she doesn't have time to fill out the forms online or on the Oryx system?
Well, and I think Jeremy is so fabulous when he talked about this on his thing, because listen, I have to be able to say, and I'm just simply going to quote Jeremy's team. I know them well, they're fabulous. Well, you know what, let's reschedule your appointment, because one of the things we promise you is that our doctor will always be prepared. And in order for us to be prepared, that information is essential. Now, here's the asterisk on that. There are some patients, older ones, who either don't have access to the internet, or who just don't know how to do that kind of thing. I better find that out on the first phone call, because if that's the case, I'm going to invite that patient to come in at a time that I'm not going to say come in 15 minutes early. I'm going to say your appointment is at 1:15, and one of the team members is going to sit down and go through that with patients. But yeah, I mean, Jeremy's just got that one down. Listen to his webinar. He's perfect.
So Shauna is saying our office is probably switching to Oryx. Yay. You really seem like you are interested in the patient and their problems and wanting to build the report, which I really agree with. My initial feeling of Oryx is that it does the opposite. It is relying so much on data entry and assessment just so you can check some boxes. Does it not take away from the relationship with the patient, focusing more on the hardware, computer work, instead of software people?
I think that's an excellent question. And I think it absolutely could be the case if you use it as a Xerox machine. But that's the case with any software system. I have seen people, when a new patient calls, they're on the phone and they're saying, the patient is trying to tell them something. They said, no, I'm on line 4. Don't tell me about line 7. That's what's happening then. Here's what Oryx does. As I understand it, and Ronnie, I'm going to bounce this back to you. It has places where you can record a lot of information that COIS trained dentists care about, but had no place to put previously. And it brings it all together to give meaning to that information. So yes, you can certainly get caught up in filling out a form, a piece of paper form, or you can get caught up in data entry. But the idea is that this is a tool that gives you advantage of information that you now can use to connect better with the patient. So I'll pass it to you from there.
Yeah, and I just want to say, we never, like when John said to me said to everyone in one of the courses, I can't see anyone without them having the medical and dental history questionnaire from the COIS Center filled out. I'm like, whatever. And then I had a few of these and I understood what he meant, because now I know, does the patient say that my teeth could be whiter or I'm embarrassed to smile? I never had that level of data. Someone who says my teeth could be whiter, it's a good thing to suggest a whitening for them or some cosmetic work, but someone who says I'm embarrassed, it's a totally different story. So it gives you a much, much higher level of understanding. If someone says no to all the questions in perio and they have bleeding gums, their gums are so red and they have no idea, you can't come and just tell them, you have perio disease, you're going to lose all your teeth. You need to ease them into it, rather than someone that says, yes, we have periodontal disease in my family. I've known this for years. I've been treated for it. I don't take great care. And they have a different level of understanding. So it really gives you a much, much deeper understanding of what the patients want. And the fact that we have the forms picture-based, it's really engaging for the patient. So we saw a much higher completion rate when we switched from yes, no answers to the photos. Right. Patients really like to complete them out.
That information and the way you get it is very much like taking the first olive out of the jar. I mean, it gives the patient an opportunity to tell you why they're there in the first place, what matters to them.
So Sandy, Veda Avery is saying that she's sorry she spilled water all over you during symposium.
Hi there.
And she's saying,
it's dried by now.
Good. As we are only suggested to treat emergencies, some patients are calling for treatment that are not emergencies. How do you explain nicely so the patient is not offended?
I just think you have to say the truth that right now the state regulations or in your case, the provincial regulations do not allow that. And I don't want to put you at risk. I'm certainly not prepared to put my team at risk. And let's talk about what we can do as soon as we can do it, because I am all here for you once these get raised and we can start seeing patients for non-emergency issues. I just think you have to draw the line. It's a safety issue, isn't it?
Yeah.
Yeah.
So Sundar from New Zealand is saying, speak the truth with love is what you're imploring, Sandy. Feels like I am listening to a female version of Dr. Coyce.
I hope, listen, my dearest hope is that I'm a behavioral edition of Dr. Coyce. I so admire his ethics and his approach to patient care. And that's one of the reasons why I've been so committed to him over the years and so engaged with the Coyce Center, is that all of these behavioral things, they fit perfectly with a high standard of care, with an obligation and a responsibility to do the right thing. So thank you very much.
So his question is, how will you approach a conversation with a person who wants to move to another clinic just because they have moved house within the town and don't want to drive across town?
Yeah. And that's a really interesting thing, because I've learned so many times that if they're paving the parking lot of your car park, if they're paving it, patients will decide to go to another dentist. Patients can leave you for the most incredibly minuscule of reasons. I'm so sorry to hear that. We would love to keep you as a patient. And if they insist, this is what I would say to them. I hope that when you go to your next dentist, you will ask yourself whether or not the standards we have provided and offered you are the same as what you're getting. Because if you decide at any point that you wish to return, our door is always open. We are committed to you wherever you go. You can come back anytime. I never want a patient to feel that they can't return, not just with their tail between their legs, but with their head held high. I love it when patients come in back to the practice and say, you know what? I did try over there. Boy, were they awful. And so the question is, coffee is one thing, but if you don't have people in your team who represent all of that high behavioral and clinical standard of care all the time, who know patients, not just whether they have a dog or a cat, but why they're coming and what their issues are and what their price testing issues are. They're going to go to somebody else and they're going to run them through a mill. You know that, right? You want to have such an indelible impression. People get to price test you too. So they're going to go over there, and if it's no different, then you've not done a good job of differentiating yourself. I believe you have done that. Let patients try it. They'll come back. Many will come back.
Hillary is asking, what is the best way to encourage confidence in ourselves as individual team members when taking on a potential difficult phone or in-person conversation with the patient where we may be concerned about the patient acting badly?
Okay. I love this question, Hillary. This is such a good question. I think about these interchanges and exchanges with patients like a tennis match. The patient is on their side of the net. They have to hit their ball when it comes to them. We're on this side of the net. We have to hit our ball when it comes to us. So part of what we can't do is run around and try to mess with their ball, and they're not allowed to come around and mess with ours. So we have to understand the boundaries here. And this is where we can do, people hate role playing, but at a certain point, you either have to do it in real life or you have to give it a whirl, right? So I know Mrs. Jones called and left a message on the voicemail blah, 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 whatever it is. I have to put on my big girl knickers and I have to be prepared to make that. So I'm going to make that phone call. Mrs. Jones, this is Sandy from Dr. Smith's office. I was so distressed to hear your phone call. And I was a little unclear. See, I'm always going to say that. I was a little unclear about what your issue is with us. I just hit the ball. The ball's on her side of the court, of the net. I just sit there and listen. Now, maybe she says something. I've always said to people, you can script a speech and a play, but you can't script a conversation. There is no amount of verbal skills to memorize that can help you engage in a difficult conversation. But you have to be prepared to say your position. I was distressed to hear that. I'm confused. Please help me with that. Listen to what this person has to say. And if this person is raising a legitimate issue, I have to acknowledge it. You know, Mrs. Jones, I think I would feel the same way if that had happened to me. That's not my understanding of what happened, however. My understanding is this, that, and the other thing. Now, I'm not trying to get in a pissing match with this patient. I'm just trying to make sure this patient on the other side of the net feels heard and understood. Did we hear her? I'm sorry to hear that. I would probably feel the same way if that is what happened to me. And if that is what happened, I have to say, on behalf of all of us, I am so sorry. I want to apologize. That's my side of the net. How can we fix this for you? The ball goes over there, and I listen. That's the way the conversation goes. And you can, it's really hard to role play these because if the person you're role playing with just wants to be the queen bitch of the universe and make it really, really hard, they can do that. And then you don't learn a whole lot of it. But there are times when you just have to engage. And this is why the dentist has to be so supportive of the team. I have to have permission to screw it up. I tried this, doctor. You know, I called Mrs. Jones. I talked with you guys about it ahead of time, made sure we were on solid ground. I called Mrs. Jones. She said, well, I've never heard anybody as rude as you in my life, and hung up the phone. I just have to say she hung up the phone on me. She thought I was rude. Because it's when we try communicating and try different ways of being with people over and over again, and you cannot use the same words all the time. Every situation requires different language. And so you've got to ask yourself, if I were in this person's position, how would I be thinking and feeling? You've got to acknowledge that. And then you state the position of your practice. You know, you wouldn't write off my insurance, or I got this insurance thing that said they're not covering this. And I said, well, you know, if I had thought everything was going to be covered, I would be upset as well. Let me just review what we did talk about with you. Because I don't know how to resolve that, because insurance companies never blah, blah, you know, and then what I'm going to say. So we just, you know what, we just have to jump in the pool and start dog paddling. That's all I know how to say. We can do trainings, we can help people with it, but my experience is that mostly people want to say, okay, now how did Sandy say that? It can't be how Sandy said it. It's got to be, what is the right thing for us to say now? And then we go from there.
So, related question. We have had a small number of patients say the DH is stupid and refuse to answer it. Any idea how to handle?
Well, if someone thinks it's stupid, then they may not be your patient. I mean, seriously. They could go to a drive-in dental office, wherever that may be. I have no idea where they would be, where you just drive in, open your mouth, and somebody does whatever. That's a standard of care issue for you. You're unwilling to, in Jeremy's case, even see a patient, and perhaps in other patients, treat a patient without a dental history. And that has happened. this is where team members need to be able to protect the dentist. Patient comes in and says, why do you need to know all of this stuff? In the absence of that, we could do you harm, and we're not prepared to do that. Well, I'm not going to answer this. Just have the doctor come in and talk to me. I need to know I have permission to not waste my doctor's time with this bozo, right? And I'm going to say, Mr. Jones, I do appreciate your coming in, and I understand what you're saying. I can't agree with it, and I know our doctor wouldn't agree with it. So I think perhaps it's probably a good idea for you to see another dentist. Let me give you your paperwork, whatever you filled out back. And thank you for coming, and I'm sorry we weren't able to help you. And dismiss the patient right then and there. Don't waste the doctor's time. You know what happens we talk about it, well, he didn't do this, and the doctor gets involved, and everybody gets involved, and we talk about it for hours at lunch. Look at all the energy we've wasted on a person we can't even help in the first place. Don't even go there. Just dismiss the patient.
I agree.
I knew you would.
So Dina Lu is asking again, Oryx has some wonderful patient education reports. Do you recommend titrating that information to prevent information overload? Maybe Rania can also comment on how or when to deliver the risk assessment and home care instructions.
Let's talk about what information overload is. A bunch of bullshit that doesn't relate to me is overload. One of the things that these reports do is that it's like I get my blood done. I don't have a thyroid, so every 6 months I get a blood test, and they tell me this and that kind of stuff. I get the information back. It's all about me. I care about those numbers, because it's all about me. If you put a bunch of crap in there that is not about me, that's overload. That's stuff I want to get the hell rid of. Don't tell me about your financial policy until it's relevant. Don't do any of that. Your hours and that kind of stuff. That's fine, but it contributes to information overload. Tell me about something that's relevant in the moment. And I do think that the patient reports and the wheel and everything, relevant. So I think overload is stuff that doesn't relate to the patient at that time. And that if that's what you're focusing on, you're probably on very good ground. That's my thinking. Rania, you can, I don't know about the titrating the information.
Yeah, actually, I'm going to ask you the question, when do you recommend doing the risk assessment, presenting the wheel with the 4 different categories to the patient and explaining their condition? Do you typically do it after they have their initial examination right on that day? Do you bring them back again to present along with the treatment plan?
I as a non-dentist, I would do the clinical examination a little bit differently than John, just a little bit. As I don't know, as we're going through the steps of the clinical examination, I would identify clinical findings that relate to the patient's issues. And one of the things that I loved about these onion skin written letters from Bob Barkley is that they said things like, you have 4 missing teeth. They are your wisdom teeth. Many patients find that that is not a bad thing because it doesn't cause additional crowding of the remaining teeth. Or you have 4 missing teeth. They are on the lower right-hand side. This is likely a problem for chewing on that side of your mouth. So something that and it was really simple stuff, he said. It was that simple. So I keep saying we need to give patients the full meal, but in bite-sized portions. Don't give them a hank of meat. Give them bite-sized portions so that they can chew and digest it. So my feeling is that if you've engaged the patient, rather than just having them lie there like they're comatose during the exam, point out things. Here's something that's concerning me. We're going to look at that and see what we see on the x-ray. Or this tooth is chipped off and broken. Is this the one that's causing you any discomfort? Those kinds of things. Engaging the patient, getting their brain in here. Then you've got that wheel. You can produce that right away. And not necessarily the dentist. You got a really good facilitator, patient coordinator, assistant, whatever it is, who can sit down and say, look, you've heard what we talked about today. Here's a way, this is something to help your memory about all of that. Because if we didn't write it down, we'd forget it. And of course, we didn't let you write anything down. So this is our way of giving this back to you. And I actually would print out a tooth chart for them as well. I would. And then on that, while the person is sitting there with the patient coordinator, because that's what's going to lead to the treatment recommendations later, to say, you see these areas of red, this is the pain that you said you had up here. It's this upper right-hand side. That's a concern, or whatever you can give them. And again, it's not overload because it's their mouth. It's them. So I would do that as much as possible, contiguous to that examination.
So Dina, I just want to add something to what Sandy said. When we're doing our exams, we have the dental history and medical history questions that pop with the patient's comments. And I found, just like Sandy said, when my assistant would read what the patient said in their exact word, because it's readily available. So if I'm doing the TMJ exam, I have what they said in the TMJ exam. So I would be about to say, you're fine. And my assistant would interrupt me and say, so Mr. Jones said that he has clicking on his right jaw joint, and that happens only when he's eating certain foods. And that prevents me from saying the wrong thing to patients, but also repeating, like if I say decay on number 3 mesial, my assistant would interrupt and say, this is the area where you said you're getting the food packed. So it's a lot more relatable to the patient as you're doing the exam. And then when the risk assessment comes in, they know exactly what we were talking about, and we could point again the areas. So my assistant is really listening during the exam, and she's facilitating that communication with the patient.
Perfect.
And this is something that Sandy teaches a lot. And I'll tell you that once I started implementing this in my practice, my reviews changed from nice coffee bar, great location, close to metro, clean office, like who would have a dirty office? But anyway, these were my reviews at the beginning, to a very thorough exam. They really listen to you. That's the place you need to go if you need serious treatment done. And there was a lot of things said about communication, listening to my concerns. They understand you, they work with you. And I mean, you had a huge impact on teaching us how to do it that way. So thank you for that. Dina had another question. Delta Dental is significantly lowering specialist fees. How would you explain to a patient why you are no longer a provider?
Very, very long answer to that. But in general, the message has got to be that sadly, Delta Dental is engaged in practices that force all dentists to lower their standard of care, and I am unwilling to do that. You have come to rely on me to be truthful, honest, forthright, forthcoming, clear, directed in all ways to looking at what's in your best interest. And Delta Dental is now engaged in practices nationwide, which are intended to increase their profits by lowering the way that they are reimbursing dentists, all dentists. Some dentists will be able to stay on this because they're prepared to lower their standard of care, but I am not one of them. That's the message.
So Rabia is asking, does Sandy have someone else who represents the way she recommends to build a behaviorally sophisticated since I know she only takes on a few specific cases at this time, and I'm young and my ownership is still a couple of years away?
I am me. I don't have little, minions around me or whatever it is. I do have lots of learning materials on my website, prosynergy.com. I'm hoping to make them more readily available to people, particularly when there's that much time. They're not very expensive to start off with, so that's one advantage for you. And then, you know, I'm always happy to talk with people. I mean, I want to help. I want to help people understand and incorporate these behavioral issues in their practice. And you know, I'm somewhat at the end of my career. I just want to help people. That's what I'm about.
Sandy, they're asking about your website again.
It's www.prosynergy, PROSYNERGY.com.
So Rabia has already downloaded some of the books and she's reading through them and she likes them a lot.
Good, thank you.
Please mention that No Stones Unturned by Sandy is so exceptional. Everyone should listen.
Oh, thank you. Oh my goodness.
Yeah, I mean, you've had so many people over the years. So one question is, during this downtime, how do you recommend to get our practice to the next level? How do we train our teams? What's the best way?
Certainly there are learning materials out there, but I think you don't need to buy anything or engage a consultant or anything. I think this is there are two exercises that, or maybe three, I'll come up with a couple of them and see how I go with it. There's a very simple exercise. It's not a drinking game, all right? So I'm going to tell you this at a time. It's called 5 questions. So every member of the team comes up with a series of 5 questions. They always wanted to know about their dentist, but they either were afraid or they didn't know how to ask. All right. So what do you believe about this? What do you believe about that? What's your position on whatever it is? Stuff you want to know and understand. At the same time, the dentist comes up with 5 things I wish you really knew and understood about me, but I've never told you, or I suspect you don't. Now, I have just a little bit of a tail end of a cold here, sorry. Then you have a team meeting. And in the team meeting, you just pull a name out of the hat and whoever goes first is that person. And I get to ask my doctor one of my 5 questions. And I just ask it. And the doctor sometimes it's, I never thought about that. Sometimes it's, you know, I thought I'd been clear about this. You know, dentists, they're so amazing. You guys are so amazing. You think people can interpret from your behavior what you think. It's not true. You are not good actors and actresses. So it's important for you to acknowledge, well, you know, I thought you understood that about me. Let me convey this to you. This is particularly the case when dentists they go to the Coy Center for, you know, a program, and they get all of this information in their brain, and then they come back and they think everybody ought to understand how their brain is different and what they're thinking about. But of course, that's not true. So you've got dentists, we want all the stuff that's in here to come out of your mouth. And this exercise is a really good way in which that happens. So that's the first 5 things, 5 questions. That's one. Here's another one. Go into your computer and ask yourself, let's go to 3 weeks before we had to shut down, and let's find a person on Tuesday who came in, and let's put that person's record up on the screen. So the question is, if we go back to this, what problems brought that patient into our practice for the first time? What is that patient's agenda? Do we know? Do we have any idea? What are the clues? What have we recorded? If this patient called and said, I have a problem over here on the lower right-hand side, would I be able to get to a chart that was complete and had information so that I could, on the phone, begin to relate to that patient? That's that broken tooth, I suspect, Mrs. Jones, blah, blah, blah. So those are the kinds of things that you can start doing. You can start immersing in helping people get a better understanding of what's going on with your patient base. People on your team will often not know and understand some things about clinical issues. It's time now for you to have a clinical lunch and learn or a Zoom meeting or whatever you can, so that everybody starts to get information and knowledge that they probably should have had. Now is the time for all of that to happen, because you're not in the throes of everyday behavior. So that's one. Another thing you can do is walk into your rooms and reception with a fresh eye and say, what have we gotten used to? The dead plant in the corner? It's dead. Let's get rid of it. Or look at your physical space. Perk it up a little bit. Do some things to help you make sure, are we cleaning our bathroom enough? That's that physical plant review. That's a stranger will come in and tell you what's going on and give you information about that, but you need to be looking at that yourself. The other thing is, in addition to the 5 questions, you can have another exercise when your team members, I've got something printing over there. It's making noise. I'm sorry. Your team members may not understand all your clinical procedures. So if, let's say you're placing implants, your team members need to understand what the specific steps are. When do you place bone? When do you not place bone? How do you determine what size implant? What's a healing cap? At what point do we take the impression? How do we do that? That kind of stuff, your team members need to know that. So part of what we're asking them to do is become more knowledgeable about the process. Because if a patient calls and says, I'm coming in for this healing cap, I don't know what that means, the person answering the phone better bloody well be prepared to answer that question knowledgeably. Lots of stuff you can do now.
Yeah, so you recommend taking a few patient charts and going through them with everyone on the team, explaining their specific roles. So the hygienist saying from her eyes the way she looks at that, and the dentist from her eyes the way she's going to see it, the way she's going to treatment plan it, and everyone is on the same page.
Perfect. And what do we know about the prices this patient is being asked to pay and blah, blah, blah. Yes.
Okay. So another question is, after this pandemic, as patients are going to start coming in, what are the verbal skills? What are the questions do you anticipate them asking us over the phone?
Well, don't you think they're going to ask about how safe you are, how physically safe you are? We will get, as we go through the last bits of the immediacy of this pandemic, we're going to start getting guidelines about how to keep ourselves safe and our patients safe. It may involve, depending on the politics and where you are, there may be a more stringent series of guidelines for you. I think it's really important for every single member of your team to know what your clinical standard is, what safeguards you are making for yourself and your practice. I mean, you guys have got to start getting N95 masks. I have no idea where you're going to get them. You guys are going to have to start probably paper dresses and throw them away after every patient. You're going to have to do new cleanup. It's going to be way more rigid than ever before. So you need, that's where you need to do an in-house training on that whole thing about how you take care of everything, gowning up and gloving up and face shields and that kind of stuff. But then you've got to be prepared to talk about it with your patients. Mrs. Jones, we've gone way out of our way to understand what the new clinical protocols are for treating people safely in our practice. And I want you to know what we will do and what we will be asking of you. You may ask a patient to wear a mask in the practice when they're not actually at the chair with their mouth open with the screens and that kind of stuff, getting care. I mean, the stuff you're seeing on the boards and everything right now about how people are protecting themselves and putting patients into these bags. And I mean, maybe that's what we're doing. I have no idea. It will certainly be way better once we get full testing, once we get contact tracing, so we know who's immune and who's not. And at some point you may be able to share that with your patients or know that about your patients. But you guys just, this is an extra burden. It's an extra cost. I know it. There's nothing we can do about it. My husband says, don't get mad at the traffic because the traffic doesn't care. And we cannot get mad at these new precautions because we absolutely have to take care of ourselves, our team, and our patients.
So I'll ask you my question now. We had a webinar on teledentistry yesterday. We just launched that platform for our users. Do you see it as something used only during COVID period? Do you think that it's something that our users should charge their patients for? And do you see it going beyond and being sort of a new way of practice and triaging patients?
Well, I'm going to show you something. I'm in the middle of orthodontic treatment, and my orthodontist, you may not be able to see this. My orthodontist sent me, I don't know if you can see this well.
I can see it.
This, and it basically says, your next appointment will be done virtually. Please text us the morning of your appointment, the photos like the ones attached without your trays for bite photos. And I did that. I told them what aligner I was on, and then these are disgusting, but you can see I had the pictures taken, right? I used spoons for mouth retractors. and the orthodontist reviewed all of that and made a recommendation about using this particular tray 1 week longer, and I can do the other one. So yeah, I think that's going to be a part of it. And I think for many people, it's going to make some economic sense as well as other. You know, the thing about orthodontics is that it's a case fee. It's not a per procedure fee. So it's going to be harder. I don't know where we're going to go with all of this. It's going to be a new world. We're going to have to figure this out as we go. I think what we have to understand is that, and this is difficult, but it's true. Many of our patients are either hourly workers and are out of jobs, or they're salaried employees who are out of jobs. When our patients come back to us, they are going to be in a less sound financial situation than they are now. We have to understand that. Now, I know we have to balance that with the fact that we're going to be in a less sound financial situation in our practices. We're going to have to rebuild these things a bit from the ground up, these relationships, these connections. And we're going to have to understand and be very gentle with both ourselves and our patients. And while I don't believe we should ever lower our standards, we may be asked to change our expectations. I'm not a futurist. That's just what my gut is telling me. I think we're going to crawl a little bit into this, but we've got to be smart enough to figure out as we go. It's sort of like we're building a road, but our car's right behind it, and we're having to build the road out 10 feet before the car is going to drive. That's the way it's going to be for us. I wish it weren't the case, but it probably is.
Sandy, we could be here all day. It's always a pleasure to have you. We're getting so many comments on how beneficial this was for the teams watching you. They got so much out of this. Everyone is asking for a recording. Do we get your permission to send the recording? Okay. Thank you very much. We really, really appreciate you.
And, you know, people can call me, so you can give them my phone number as well. Okay.
I'll call you right after this.
Okay.
It's amazing. Thank you so much, Sandy.
You're very welcome. It's always a pleasure to work with you. And listen, to all of you, please stay safe. Please take care of yourselves. Take care of your team members. They're so, so, so important. They're going to make these next couple of years really important for you. You need really smart, switched on, engaged, and informed members of your team. And then treat them well, pay them as well as you can. And we're going to get through this.
We will. Thank you.
You're welcome.